All right, so that's a very nice demonstration, Tammy. Thank you for sharing this. These are challenging cases sometimes, and hopefully I will demonstrate the technique for removing these endoscopically and shows the challenges when you're confronted with a hybrid way to remove these. So, and my plug here is you have to commit with one pathway, but the dangers happen if you try to do too much in a combined approach, because you could create sometimes a bigger problem. But let's go over this. So first of all, you all know the components of the band. So you need to account for every single component, whether you're removing this endoscopically or hybrid approach or laparoscopically or open, because there's a certain percentage that you start laparoscopic and you end up converting to open based on the literature. And the components here especially pertains as if you try to do this endoscopically, is where do you cut this band? Do you cut it at the clasp? Do you cut it at the belly? Because the clasp is very bulky and sometimes it tears when you cut it at the clasp. So recognizing what part have migrated intraluminally and trying to tease your best attack to cut it endoscopically is an important concept when you manage this. But obviously, you could cut it nicely endoscopically, you could grab it, but it's tied to a tube, so you're always gonna need your partner surgeon to cut the tube for you. So there's no way you can do this fully endoscopically because that tube needs to be immobilized and cut, and of course the port need to come out. So I think that's, knowing these components is important for how to manage this, whether endoscopically, hybrid, or surgically. Now here's the challenge. The challenge is, the cartoons say that this is a nice band, but in reality, this band is anchored and is anchored in place and develop a cocoon of fibrosis around it. So there's a capsule. That's why you get away with endoscopic removal, because that capsule is preventing you from having a full perforation to the peritoneal cavity. And this capsule becomes your assistant if you're gonna remove this fully endoscopically. The problem happen is people think, oh, let me mobilize some of this band for you to make your endoscopic removal easier. And they're dissecting in a very fibrosed and inflamed tissue. And if all of a sudden they created a hole, so I cannot remove this endoscopically, and you cannot remove it laparoscopically at this point. And that's where the patient is worse off rather than committing to one pathway and sitting with it. So if you said the band is intraluminal and you go into the endoscopic removal route, do not disrupt the capsule because you're gonna create a hole that you cannot manage very well. Just cut the tube and move on. If you wanna do this fully surgically, I would do exactly what Dr. Kindle do, pick a healthy area of the stomach, create an access point, remove the band, and then close it, because you could close it. You cannot close a hole in this inflamed fibrotic area. You could close a hole distal to that. So that, I think that's an important teaching point here. So you could see this, we embark on an endoscopic removal, and all the surgeon partner did is cut the tube and let the rest of it be removed endoscopically in this case. So how do you do it endoscopically? Obviously, you need some band to have eroded intraluminally in order to remove it. Usually a third of it. If you have a third eroded, you could do it. Some people try to mess with cutting with scissors. Good luck. These are very hard, thick bands that cutting them with the scissors is not a very, you might spend 3 hours and do it eventually, but not the way to go. What you do is you use this instrument called a lithotripter, and we use it for ERCP to extract and crush big stones from the bile duct. But here we're using it because it's able to cut that band, and we'll demonstrate the sequence. So the component is, first, you need to get a wire, and here we're using a jag wire because you cannot break a jag wire, it's very strong, to create a loop around the exposed portion of the band. So you go with an endoscope, you put the wire through the loop of the band, and now you have both ends of the wire coming out of the patient's mouth, and the wire is surrounding the band. Then you pretend that this is a big stone in the bile duct, and you connect this stiff metal sheath that will crush it under mechanical force, and you connect it to this lithotripter. So you could see this is the sheath. The sheath is gonna follow where the wire is going, and then you mechanically will start cracking in order to have the sheath pull on that wire with enough force to create a cheese wiring effect that is enough to cut this band. You're going to have to follow the process, because if you're blindly pushing this, you could engage the esophagus and you could really perforate the stomach and the GE junction. So you have to confirm endoscopically that the tail end of that metal sheet is hugging the plastic sheet of the band before you start putting the mechanical force. And you could see with the mechanical force, you cut it and you grab one end of it. And that's why if your surgical partner did not dissect the capsule is there to protect you from having a big hole, and you just pull the entire band out of the patient's mouth, and here's the tube that comes with it. The idea of inspecting for the full portion is important. Here you could see we're missing the buccal, or they're missing the buccal. So you go back, the buccal is there, you just need to grab it and pull it out from the patient, and you get a buccal breakage if you cut it at a certain point, but you're limited with what's exposed, so sometimes this is, you cannot control that portion of it. But here you can see the full band came out, and the patient had no leak and had good outcomes. Now, the title was Band Erosions in General, so we discussed the laparoscopic band, but there's other types of bands that you're going to encounter, especially with a vertical banded gastroplasty. And if you have a vertical banded gastroplasty patient and you're having a band, your first branching logic is this a mesh type of band which you cannot remove endoscopically and you cannot dilate, this is surgical conversion, or this is a silastic band that you could easily remove endoscopically. If it's a silastic band that looks like this, and you could either put a fully covered stent to have it erode, and it will erode intraluminally like this, or if it's fully eroded, you just grab scissors and cut it. They're very easy to cut, very easy to pull, and you do not need to use the lithotripter for that. And with that, hopefully I gave you some pearls about how to deal with these migrated band in VBG and lap band, and thank you for your kind attention.